share. All right. Please speak up if you guys can't hear me. I was saying the unfortunate part of sharing my slides is that I can't see you. So today I'm going to talk about medically unexplained physical symptoms and just do a really brief overview because we have 20 minutes, but this is something that you could spend literally days of conferences going over. So just some basic concepts. Um, so medically unexplained physical symptoms are a category of clinical presentations where people come to the medical field asking for answers when they have symptoms or impairment, and we can't find a cause. We can't find an organic pathology that which we can identify and offer treatment for. So this covers lots of different issues. So it includes chronic pain syndromes. Why do some people have an injury, have brief acute pain, and then the pain subsides, and others have the same injury and have prolonged amounts of pain and pain out of proportion to what's expected. Chronic daily headache, functional neurological symptom disorder, or as we used to say, conversion disorder, somatic symptom disorder, chronic fatigue syndromes, and irritable bowel and chronic abdominal pain. Um, so things changed a little bit in the new diagnostic manual in that we changed the name of just somatoform disorders to somatic symptoms and related disorders. So we were looking at, we can't put all of these symptoms into neat little boxes. There's just like autism, there's everything is a spectrum, and not everything behaves according to the same rules for the same person even. So it recognizes also that you can have somatic symptoms in the presence of diagnosed medical disorders. One thing that a lot of people don't recognize is that a large proportion of those with non-epileptic spells or episodes have diagnosed seizure disorders. So it's about 20% of those people with seizure disorders also have psychogenic non-epileptic seizures. So um, hypochondriasis used to be under somatic symptoms, and the old kind of hypochondriac, I think everything is the end of the world. Um, it's now categorized as an anxiety disorder. So it's under an anxiety category, and it's called illness anxiety disorder, and it's considered separate from somatic symptoms. So, as I was saying, conversion disorder is now called functional neurologic symptom disorder. And a couple of the big things that I wanted to highlight are it used to be that you had to identify a stressor for diagnosis. So, to give you the classic example, someone develops what they used to call hysterical blindness because they saw something terrible. So they saw this terrible thing and they suddenly couldn't see anymore. So that would be kind of the classic example of there being a stressor and something going off. It's never that simple, or very rarely that simple. And a lot of times when people are presenting with chronic abdominal pain and chronic headaches, even neurological symptoms, there's either not an identifiable stressor or not good insight into the identifiable stressor. So you don't have to have that history to give the diagnosis anymore. You used to also have to prove that they weren't faking it. So in trying to explain conversion versus factitious versus lingering, it gets very muddy. And so you used to have to say, never is this child saying they're sick to their stomach because they don't want to go to school. It's a lot more complex than that. And one of the fancy terms, la belle indifférence, which means basically the beautiful indifference. So people would uh, say, I can't move my arm. And most of us, if our arm stopped working, would be, I can't move my arm. But the indifference of the symptoms used to be a diagnostic criteria. And now, while it supports it not being an or organic cause, it was removed as a diagnostic criteria. And the most common presentation of functional neurological symptom disorder is psychogenic non-epileptic seizures, or PNES. We don't use the term pseudo seizures anymore. That is kind of the most, they are the most frequent presentation. These symptoms are very, very frequent. Almost 20% of PCP visits, which is a primary care physician, so family practice, pediatricians, internal medicine, in almost 35 to half of specialty visits. It takes about half of the primary care practitioner's day, and about 16% of annual healthcare expenditures, which amounts to hundreds of billions of dollars worldwide. So in children, especially, about 10% of kids have clinically significant impairment at some point due to medically unexplained physical symptoms. And over half of kids report at least one unexplained physical symptom in the past 2 weeks. So a tummy ache, a headache, for which, they didn't have diagnosed rotavirus or something like that. The most common in children are headache and recurrent abdominal pain. So the traditional explanation, sorry, my mouse is getting a little click happy, was that it was a physical manifestation of some psychic conflict. But there's not a lot of evidence to support that. So, one of the things that I see still kind of as a misbelief is when kids come in presenting with this, people get their heckles up for, was this child sexually abused? Was it, are the parents physically abusing them? It's always good to have your antenna up for that. Rates of trauma are higher in kids with functional neurological symptoms disorder, but it's still only present in about a third of the patients. So 2/3 of children do not have identifiable previous trauma. And patients and parents often really negatively um, respond to psychiatric explanations for physical symptoms. So, one of my first experiences as a hospital-based psychiatrist was getting called into a room for a child with chronic abdominal pain, and it wasn't where I currently work. But I walked in, and the family was very confused. They said, well, why, I think you're in the wrong room. Like, why is psychiatry here? And the GI doctor walked in, and they said, I'm sorry, like, why did you call a psychiatrist? And I think he was having a bad day. He said, because there is nothing wrong with you. There is nothing wrong with you. It is all in your head, and you need her more than you need me. That didn't that didn't sit well, as it shouldn't have. It didn't sit well with me, and we had conversations afterwards, and it didn't sit well with the patient or the family, because that's the mistake a lot of us make, is we say that things are physical or in your head. And I always tell everyone, like, all those wires are interconnected. It's not this black or white explanation, and it's not dismissible like that. Um, so the current way we think about the etiology, the explanation of why this happens, is kind of a somatosensory amplification. Big words to say that basically something happens, and then we become focused on what happened, like, and then we kind of make our focus selective, like, and this happened a lot during COVID, didn't it? With a lot of us, we got really hyper vigilant about is that sniffle my allergies or is it COVID? I have a kind of a raspy voice. Should I call in sick to work? Should I go? So we've seen a lot more of this because a lot of people have been very hyper aware of physical sensations. And when you're hyper aware of your physical sensation, if you're having, stomach pain, then you're focused on that stomach pain and you're you can become overly focused on that stomach pain. And sometimes in situations there's reinforcement that occurs. Doctors may run an extensive medical battery that makes you feel like there must be a source. We're guilty of that sometimes. Affective factors, you're depressed or anxious. Depression, and especially in children, chronic abdominal pain and chronic headaches are very suspicious for, and it kind of related to the other, the related to intertwined with depression and anxiety. I don't like to say caused by depression and anxiety because I think it's an interwoven relationship. It's not a cause and effect. Um, and behaviors kind of, when you are used to having discomfort and that discomfort builds, you become uh, very aware of well, I right now I'm feeling good, but when am I going to start feeling bad? Am I going to start feeling bad now? And so just kind of overly focused on that issue. So, oh, there's my funny little pain scale. That 7 to 10 is meh, but the so of course, like with everything, there's kind of a biopsychosocial model. There's perception, your interpretation of how you interpret bodily sensations. If you're an anxious person at baseline, you know um, indigestion, you might think, not be in a place where you think like, oh man, I think I knew I was eating a little bit too much of that chipotle, versus oh my gosh, I think I have an ulcer. If it's an ulcer, is it an ulcer because I have stomach cancer? And kind of going down that hill. And it's influenced by a lot of things: personal, cognitive factors, the context of your illness, how it affects you. So certain things can predispose people. Um, Again, a third of patients with psychogenic non-epileptic seizures did report sexual abuse. But if you look at studies between um, patients with trauma and uh, in functional neurologic symptom disorder and controls, there's little difference in the amount of those who are presenting with trauma. And the perception is different, but the stressors weren't significantly different. So trauma or psychiatric symptoms is a factor. Prior somatic symptoms. So between 50 and 80% of patients with psychogenic non-epileptic seizures have had a history of other medically unexplained symptoms. And illness exposure. Personal or family history of neurological or other health disorder, and media exposure is a big problem right now. There was a big issue with what we call like shorthand TikTok ticks. They were actually functional neurological symptoms brought about by TikTok, and we had families of children coming in with movements that were, more like they were grooving and not tick-like in any way, shape, or form, because they were concerned that they had ticks because these were similar to videos that they had seen on TikTok. So the exposure issue is an issue. And then the symptom monitoring. If you're overly focused on that symptom, if that's all you think about, then you are much more prone to an increase in perception of severity. And there's neurobiological evidence that some people are just more prone to being more sensitive to their bodily sensations than others. So, say with functional tremors, meaning they're not biologically based, patients reported these with functional tremors said that they were having tremors 80 to 90% of the day, but when they videotaped them, in studies, they actually only had the tremor for about 30 minutes out of the day. And there were a lot, and in contrast, people with organic tremors said, oh, I think maybe 10, 20%. They tended not to overestimate as much. So, in another study, the brain activity in patients with functional tremors showed that the brain activity um, was voluntary, meaning they were kind of unconsciously doing it, but was perceived as involuntary. So it was very interesting. So what maintains? So those are some of the things that can be related to the development, but what makes these issues stick around? So it used to be uh, and why it gets muddy with convert the old conversion term and factitious and malingering is that a lot of these things have results that benefit kind of emotionally benefit sometimes the patients, but not that they're necessarily causing themselves, if that makes sense. So say a child is very stressed about school and they feel sick all week long. They're not faking it. Their stress and their abdominal symptoms are interplaying to the fact that they're sick all week, and they're better on the weekends. But sometimes that might result in them getting to stay home from school, which is going to perpetuate that and amplify those symptoms. Increased attention from others, the sick role. There's that selfie picture. We get it all the time in the hospital. I mean, you'll have somebody literally in the midst of a trauma saying like, record this, for posterity to post it. um, Cognitively, kind of like that misappraisal of symptoms that, oh my gosh, I have indigestion, I must have an ulcer, because ulcers run in your family, and your mom has an ulcer and your dad has an ulcer. So symptom focusing and intolerance of uncertainty, no, it has to be something bad. And physiological, kind of that central sensitization that some people are prone to. So really, kind of a complicated looking thing, but it's really not. This health scaffold, big words for, it's just illness experience. It's personal illness, parental anxiety about illness, illness of family members, friends, working in the health profession. All of these things can contribute to how we interpret the physical symptoms. So, physical symptoms that are catastrophically misinterpreted can lead to those symptoms being uh, causing anxiety and expectations for what those symptoms might mean and what those symptoms might do, which can worsen the physical symptoms. The sickle also can interfere and cause an increased risk of adding some functional neurological symptoms on top of that. So it's not as simple, like I was saying, as, oh, it's a physical problem, or, oh, it's in their head. So, how do we approach this? The most effective approach is cognitive behavioral therapy. And it's targeting your awareness of those physical triggers, stress reduction techniques, not panicking when you have those physical symptoms, and how to cope with those physical symptoms. We've really moved away from the ablation of all pain to how do we cope with having some degree of chronic pain. Physical therapy is really prominent in the treatment of functional motor symptoms. Psychopharmacological treatment is only appropriate if there is known underlying depression or anxiety, or suspected underlying depression or anxiety. It's not appropriate simply for the treatment of conversion or functional somatic symptoms. So, one of the things to keep in mind is, with the initial diagnosis, how do we do that communication? How do we avoid people saying to people like, this isn't physical, this is in your head, this is your head doing it to you. Your head doesn't make, it's not like you're willing this to happen. And we really need to work to educate not just the medical teams, but even just the people in the general population to, like, oh, there's really nothing wrong with him. It's just in his head. So really, having a way to present things in a way that, for instance, when I have a patient with psychogenic non-epileptic seizures, I say, we have good news. The seizures are not being caused by a neurological discharge. They're being caused by an emotional discharge that your brain is reacting very similar to an electrical discharge. And the good news is that we can work with this to go away, and we're not going to have to, take away your license or make it so you can't swim, et cetera, et cetera. So posing it that way is generally much better accepted than well, you don't really have seizures, it's just in your head. So, um, people are very wary of, psychiatric services. They don't want to be told they're crazy, which some people, are pretty blunt about that. And we have, you know, limited time here, but you don't want, families want to know what's wrong, and conveying like, oh, we don't know what's actually wrong, it is not something that's going to make people feel better. I think coming out with something very, um, very matter of fact, like we have done the tests, we know that this is not an electrical malfunction in the brain. That's good news. This is an emotional issue, this is an emotional dysfunction in the brain, or surge, and we can actually train your brain. I always taught that you use therapy to flip you from automatic to manual steering of your brain to control those symptoms. So families are more willing to listen to people who are willing to listen to them. And, they're often pretty wary of psychiatric services. So they also don't want their kids being labeled. The labels, some of the labels that people still use are pretty offensive, and complex terms, and you don't want to um, appear uncertain so that parents feel the need to seek secondary opinion because they don't feel like for sure that their child's not going to have a poor outcome. And the sooner that you introduce at the beginning of a workup for a medical problem that, like, hey, you're in here for chronic vomiting, chronic abdominal pain. Just so you know, that's something that's really difficult to deal with. So we want to get psychology involved from an early start to just help you deal with the fact that you're having these symptoms, is a lot better than doing the workup and then saying, like, you know what, you really need to talk to a therapist. So medical interventions aren't always available or effective, and sometimes they can be harmful. So we really try to be judicious in what we actually work up. Um, this is just a little blippet of a treatment plan in the last minute or two that someone might use for someone with a functional seizure disorder. And I don't generally do this work, so my colleague Kevin Treemstra was very uh, generous in it to me. So someone who has a functional seizure disorder, they draw a body map, and they look at what are the sensations that they feel, or things that are warning signs that one of these events is coming on. And then they write out the sequence. So I'm feeling hot on the outside, cold on the inside. I start feeling my throat close up, and I feel this weird taste in my mouth. I start breathing faster. They kind of identify what their experience is. And so they learn through therapy, when you start, how, okay, once I'm starting, is it hot in here? I'm going to sit down. Then I'm going to say, like, okay, I know that this is a sign that this is something, this is the start. And this is, this is what is initially just what is going to happen. And so there's the writing out, they call it surfing the wave. Um, some episodes can be averted. Sometimes you can make enough progress in therapy that you can actually cut it down or cut it out. But sometimes you can't do it all. So just kind of learning to safely get yourself in a safe space, or a private space if this is going to happen, like at school. Like, okay, I'm starting to feel hot, flushed, I'm going to the guidance counselor's office because I know it's going to happen. and then learning those calming techniques so that it's less likely to happen. But again, not always preventable. So calming strategies and cognitive strategies are what they go over within the therapy. So that is a very, very brief introduction. And I'd like to thank again Dr. Treemstra and Dr. Kaplan. Um, and those are just some of the many, many references. So